Chemotherapy is still a fundamental part of cancer therapy, but the problem with chemotherapy is its relatively non-specific mechanism of action, and so, sort of almost like, I suppose, carpet bombing, or that it has a lot of indiscriminate effects. So patients frequently get problems such as nausea, they get low blood counts which can predispose to infection, they lose their hair. It can have very debilitating effects on patients in an effort to get the tumour under control. So in cancer, over the past decade or more, there has been an increasing kind of desire to get away from non-specific treatments such as chemotherapy towards much more sort of specific targeted treatments that target the underlying, I suppose, problem in the cancer itself without causing a lot of collateral damage. When I started my academic career in haematology, I left Ireland and went to Portland, Oregon in 1998, and that coincided with the first development of a new drug called Gleevec for the treatment of a relatively rare form of cancer called chronic myeloid leukemia. Up to that time, treatment had been relatively crude for this cancer, and the only effective treatment was bone marrow transplantation. And in fact, the average survival of patients is only about 3 to 5 years from diagnosis. With this new treatment, which specifically targeted the underlying genetic abnormality that caused the leukemia, patients went into remission with little or no side effects. And patients who went on that treatment, many of the patients who went on that treatment back in 1998 are still alive. And that treatment has revolutionized the treatment of cancer and opened the door really to a whole wave of new targeted therapeutics, which hopefully eventually will make chemotherapy obsolete. In Galway now, we're trying to develop our own targeted therapies to deal with the cancer called multiple myeloma. This is multiple myeloma, where we can see abnormal large blue cells down the microscope, which are plasma cells. These are cells that produce antibodies. While they look abnormal down the microscope, what we can't see is that these cells are heavily coated with sugars, and the presence of these abnormal sugars on the surface of the cells heavily influences their behaviour, leading to drug resistance and the spread of this cancer around the body. So we think that an important part of the development of this cancer is the expression of these abnormal sugars on the surface of the cells. This leads to the development of drug resistance and to the spread of this cancer around the body. What we are doing in Galway is developing treatments that will overcome the abnormal sugars that are present on these cells, rendering the cancer cells more sensitive to chemotherapy and reducing their spread. In Galway, we have discovered that genes that are involved in the production of these abnormal sugars are overexpressed in patients with multiple myeloma, and that this can lead to poor survival. We're planning to bring this treatment to clinical trials which will be available to patients in Galway and in the United States for patients with multiple myeloma. We are already involved in early phase clinical trials with other compounds that are very promising in multiple myeloma. We recently opened the very first phase 1 clinical trial in multiple myeloma in Ireland, and the results of this are very promising and will be presented as an oral presentation at this year's American Society of Haematology.